So thank you very much, Monica, for that introduction. And of course, very happy to be here and speak about the current status of what's happening in the continent as far as pharmacogenomics in Africa is concerned. It was a very inspiring talk from the previous presenter, and I'm very confident that we'll probably be able to find towards the end of the presentation some common ground in terms of forging a new partnership that would be very exciting. Of course, everybody here knows the Human Genome Project was a massive undertaking by those two folks in the picture represented. And what this really allowed for is to create a database of all the sequences of the human genome, particularly 3 billion of them, and to put them into one sort of database that would allow us to understand what would change if someone was to get sick, and so on and so forth, which in fact is the premises of how precision medicine can be seen. However, it was much later that we understood that in fact the data that was captured by the Human Genome Project did not necessarily capture, in fact, it didn't capture the genetic variation of the African population. This is a continent of 54 countries where we've got more than 2,000 languages being spoken, and of course the diversity of the different people, different ethnicities is greatest compared to any place in the world. Subsequent studies that were looking at the genomics of African people clearly showed that Africans as a continental population had far more number of genetic variation in their genotype compared to any other population around the world, as you can see from that picture where the orange and yellow spikes represent all the variation that come from populations in the African continent, whereas the rest of the colored populations are in fact quite significantly lower. But also at the same time, it was abundantly clear in subsequent studies that African populations not only have greater number of genetic variation, but they're also quite diverse from each other. This is a picture of a chromosome 10, 11, and 12. And as you go from left to right, you're basically going from West Central Africa to South Africa to East to Horn of Africa to North. And every time you move from region to region, you see colors changing. That indicates that the sequences of the chromosome 10, 11, and 12, in fact, are changing as we move regions. But then if you look at Europe, it still remains homogeneous, whether you are in France or whether you are Spanish or Russian or Italian. There's a lot more homogeneity in terms of the genotype within the European context as compared to the African context. And so much more later in 2019, 2020, predominantly African-led studies showed that African genomes that were captured through these studies, in fact, when they went back to the database of the Human Genome Project, there was about 10% of the DNA sequence that was found from these African populations that was entirely missing from the Human Genome Project, and therefore it sort of cements the fact that Africans were not very well captured during the Human Genome Project. And this has, of course, consequences to what I'm going to be talking about today, and that is pharmacogenomics, which in fact is just a study where we're looking at the different variations of the genetic variation that influence how someone will respond to specific drugs. And in fact, pharmacogenetics it was born out of combination of different traditional pharmaceutical sciences like biochemistry, but then with genetics and trying to understand how DNA variation from the Human Genome Project actually influences on how people would react to different drugs. Now, we all, of course, know that the patient population or the disease population that looks at different drugs for different diseases. In this particular picture, you see different drugs trying to cater for different diseases like antidepressants, asthma, diabetes, arthritis. And what happens is that not everyone who will receive a drug of the same type, even though they might have the same disease, will benefit from that particular drug. And that sort of cements the idea that, in fact, one size does not fit all. Some drugs will be more better working for some types of people, other drugs won't, and so on and so forth. And so this is typically what a picture of a patient group that might be suffering from the same disease or same diagnosis who have been given with the same prescription, in fact, end up in 4 different groups. There is that group that might not necessarily benefit. In fact, the drug will do harm. The other group will be that they might benefit, but then the drug still does harm. And then, of course, we all want to be in that group where the drug is not harmful, but it's also beneficial. But also sometimes we can be in the yellow group where the drug is not necessarily toxic, but is also not beneficial. Now, the key to understanding which category of the group that we really belong to would be undermined by the fact that we need to understand the genetic variation of our genotype. And so that's where the whole concept of precision medicine actually comes into effect, where you have a specific patient population with a specific disease. And ideally, when we use our standard or conventional approach of treatment, in fact, only 20% of that population will effectively benefit from that treatment strategy. And about 80% of the drugs that we're prescribing to the general population with the same disease, in fact, might go to waste. However, if we take into account the genetic information of a specific population, we will be able to afford a better tailored approach to treatment plan for that particular patient. And therefore, by understanding the genetic variation of that particular person, we might be able to prescribe a specific treatment that might work for a specific genotype. And then hopefully that would increase the effectiveness of that particular drug and reduce that wastage. So, of course, there are many factors that, in fact, affect the variation of how someone might respond to a drug. And of course, that is determined by genetic but also environmental factors. And all of that, in fact, will affect how you absorb the particular component of the drug, how you distribute it in your body, how does the body actually metabolize it. In fact, a very important component of the body is how does it metabolize. And of course, lastly, the excretion part. So all of these factors are extremely important to understand how a person will tolerate or not tolerate a particular drug, depending on multiple factors. And what we have seen so far, and of course, this is a picture from 2017, that there's quite a number of information regarding the drug gene pairs that has been recommended by the US FDA list of these biomarkers, where a huge chunk of that comes from the oncology sector. And then we've got the sporadic sort of psychiatry with 12%, infectious diseases, and then the rest of the subfields of medicine, each of them with single-digit sort of percentages. And if we sort of now zoom into Africa, there's quite a number of pharmacogenetic studies that have been conducted within the African regions, and a huge chunk of that, in fact, are looking at the African American population, which is a subsequent, category of Africans that really migrated out of Africa and went to settle in northern part of America. Whereas, the other chunk of the population that's being studied pharmacogenetics is the North Africa with about 33%. And then the rest of the continent or the region of the continent is divided as so. And if we look at where these pharmacogenetic studies within the continent, what they are really focusing on, it's about 15% is looking at infectious diseases, about 14% is looking at diabetes, 18% is looking at cardiovascular diseases, 16% is looking at kidney disease. So we've got sickle cell, hepatitis, that cardiovascular diseases. These are, in fact, the areas that most of the pharmacogenetic studies in Africa are, in fact, focused on. And one of the most important, of course, things to understand is pharmacogenetics, of course, affects the genotypes in a drug metabolizing enzyme. And so what you can appreciate in this picture is that the area between the darker and lighter lines for each graph indicates the difference in area under curve for each respective genotype. So the gray dashed line indicates the upper effective concentration required. So A represents individual with no capacity to metabolize a drug, and therefore if it's accumulation, it could be due to homozygosity or heterozygosity for a defective allele that in fact severely affects or abolishes the enzyme activity, and therefore for those kinds of patients, you probably want to have as lower dose as possible. The picture B shows heterozygotes. This is made up of either active or inactive alleles, or different combinations of low activity alleles that reduce activity with different effect sizes, but do not necessarily completely abolish the activity. C represents individuals with normal activity who would be homozygous for active alleles and would require normal doses, whereas D are individuals that carry duplicates or increased copy numbers of normal active alleles, which leads to faster metabolism of the drug. And because of that, it might lead to failure to reach the therapeutic drug plasma concentration levels. And therefore, for these kinds of patients, they might require higher doses. If we look at sort of the general global distribution of the CYP2D6 haplotype, which is very, very important because it's one of the most pleiotropic drug metabolizing enzymes. And in fact, it is involved in hepatic clearance of almost 25% of all clinically used drugs, which is a huge amount, including antidepressants, opioids, antiarrhythmics, and many other drugs. And so if we look at the global distribution of how these phenotypes work, and when we look at the frequencies of these CYP2D6 poor metabolizers, we've got the image A on the top left that shows regions that are, poor metabolizing for this particular phenotype. And then we've got the intermediate metabolizers and ultra-rapid metabolizers. So looking at different populations around the world is extremely important to understand the context of the population in terms of how they will really react to a specific drug, and depending on what phenotype they have, and how these frequencies are important to tell us what the dose of a specific drug for that population should be. If we sort of zoom into the African continent, we're looking at a graph that shows the distribution of the CYP3A5 haplotype, which in fact is a very important allele that looks at association of disease risk and metabolism of these steroids or xenobiotics in many tissues, including lung, kidney, prostate, breast, and leukocytes. And we are clearly seeing here that this particular study that was done, we're looking at about 2,245 individuals from 32 different ethnic African populations. And, these allele combinations at all three loci are in fact given in the key, and the alleles in brackets define the inferred haplotype. And we find that the lowest star3 frequencies are in fact found in sub-Saharan Africa, although frequencies can be slightly seen higher in East Africa than any other population sample from the continent. So this kind of information tells you that there's a lot of diversity even within the continent of Africa when we are trying to understand how populations will actually be affected by the genotype of that particular population with respect to what that particular haplotype will do in terms of metabolizing that particular drug. Now, zooming into also what we have so far in terms of pharmacogenetics as far as clinically actionable variants is concerned, and thanks to, of course, the Dutch Pharmacogenetics Working Group that provided us with these guidelines for dosage for very commonly prescribed medications. So all these blue drugs that you see are in fact related to pharmacokinetics, whereas the red drugs are all related to the pharmacodynamics. And in fact, these specific drugs that affect that specific gene are all actionable variants, and in fact can be used even within the sub-Saharan Africa, even though there is not much data available in the continent. But there is already some sort of commonality that some studies can already be looking at different variation that's present in these genes, and how in fact they can be used for tailored treatment for patients within sub-Saharan Africa. Now, what we've really been able to accomplish in Tanzania is, of course, related to the most pressing public health concern as far as genetics is concerned is this disease called sickle cell disease. Sickle cell disease is a monogenic disorder that's caused by a single mutation in the HBB gene on the 6th position, where the glutamic acid converts to valine, which subsequently will produce sickled or banana-shaped red blood cells as opposed to a normal-shaped red blood cells. And the accumulation of those sickle-shaped red blood cells, in fact, causes all sorts of vaso-occlusive crisis and pain and even mortality. So, in fact, the numbers in Tanzania are quite staggering. We've got about 11 to 14,000 children that are born with sickle cell disease every year, and unfortunately, more than 50% of those will not survive post the age of 5, which is terrible, and this is a public health concern. Now, at the moment, one of the most important things as far as treatment is concerned is the use of this drug called hydroxyurea. And what hydroxyurea basically does, it sort of keeps the fetal hemoglobin intact and prevents maturation to adult hemoglobin, because patients with sickle cell disease, when the fetal hemoglobin matures into adult hemoglobin, they don't produce HbA, but they will produce HbS, which becomes the sickled hemoglobin. And so the idea of hydroxyurea use is to keep the fetal hemoglobin as intact as possible. So some of the things that we've tried to explore and this work, of course, was being led by Dr. Siana Nkia and team, is to how do we try and use the genomic medicine approach to really use sequencing and pharmacogenetics to understand how hydroxyurea can be used for treatment of sickle cell disease in Tanzania, and how can we then categorize these patients that have specific variants that gives us information as to whether or not these patients will benefit from the use of hydroxyurea or not. So, of course, I've mentioned Tanzania is indeed one of the 4th, in fact, highest incidence rate countries in Africa with sickle cell burden with significant morbidity and mortality. And hydroxyurea remains one of the most important drugs for the management, particularly reducing the vaso-occlusive crisis. It also requires transfusion and so on and so forth. Now, despite the benefits of hydroxyurea, we still find that about 30% of the patients do not respond optimally to hydroxyurea, which means that even within the Tanzanian context, we have to now understand what are the genetic determinants of responses of these patients to the hydroxyurea drug. So what we did was we created a custom Illumina AmpliSeq panel where we targeted about 13 genes that are implicated to have an influence on how the metabolism of hydroxyurea is done by the body. We initially tried to pilot using 60 sickle cell disease patients, where we tried to understand what are the common and rare variants that influence hydroxyurea response. And of course, we achieved that by achieving high quality, targeting coverage. And what we did find was that we could create a robust tool, in fact, for personalized medicine in Tanzania using sickle cell disease and hydroxyurea as a drug for the first time in Tanzania. So this really represents the first Tanzanian hydroxyurea pharmacogenomics panel, which in fact tells you that it is indeed possible to do these kinds of things in the land of Africa for diseases that are in fact quite significant in our setting. After we've designed the panel, we then went on to perform clinical studies where we further recruited a cohort of about 148 patients, all of them between the ages of 5 and 30, that came from Muhimbili and other regional hospitals. And what we did was we gave them hydroxyurea at 20 milligrams per kilogram daily, and we monitored their responses over 6 months. What we did find was that we had about 49 people that actually were good responders. 11 of them actually showed minimal change. That means that they are poor responders. And then some of them are in fact non-responders because they have a high pathogenic genetic variants. And what we did see was that these genetic loci that were linked with the hydroxyurea response were actually found in multiple genes as highlighted in this slide. And so what we really learned from this particular study was that there's a lot of evidence of genetic variability to understand why certain patients respond or not respond. What we did find was that good responders carried favorable variants in those genes, whereas poor responders carried more deleterious SNPs. And so this is, in fact, a very interesting finding, which would support the hydroxyurea pharmacogenetic testing as a predictive tool, which in fact allows us to build foundation for personalized dosing strategies, to develop alternative therapies, and in fact integrate genomic medicine into national sickle cell disease care. But of course, now when we talk about really implementing this at a continental level, implementing this at a national level, one of the most important things, or one of the most important discussions that come up, is how do we deal with the economics? How do we really understand the importance of the health economics, particularly if you want to translate pharmacogenetics in Africa? And so, of course, as I mentioned before, Africa has the most genetically diverse population. It also is the continent with the highest burden of infectious diseasing. And what we are now seeing is there's a huge rise in the non-communicable diseases as well. What we do know at the moment in terms of existing global data is that they don't necessarily represent African context. As we all know, in these global genetic data sets, I think about Africa represents less than 1% of the data that's actually available. And so that has negative downstream effects as far as diagnostics and therapeutics is concerned. But of course, pharmacogenetics, we see it as a sort of a low-hanging fruit, because it really allows us to understand stratification, particularly to identify responders, non-responders, and those that are at the risk of toxicity, which in fact, in the long run, might help hospitals and the government to take measures to understand what is the quantity we need to buy, the quantity that we need to avoid to give people because it's basically wastage. And of course, retention of these drugs otherwise discontinued because of adverse effects. And what we've seen as far as case studies in terms of the use of pharmacogenetics in Africa is concerned, we've seen clearly how the variants in the CYP2B6 variants impact efavirenz dosing, particularly for patients with HIV. A beautiful study in Zimbabwe was done where they showed that those people that have a specific variant from that particular gene, in fact, will not be able to metabolize that drug, and so there needs to be a dosage alteration for those patients. And similarly, we've got multiple examples of how variants in different alleles show their effect on the dosage requirement, but also in terms of whether or not these drugs should be given to those patients for malaria, for TB, for pain management, but also for prescription of chloroquine, particularly in Senegal. So we've got many case studies in Africa that have looked at different types of effects of pharmacogenetics in the continent. However, we still need to shout out more in terms of what is really the importance of the clinical outcome and the economic benefit, particularly for our policymakers. One of the things, of course, which is sort of a no-brainer, is that it's going to reduce the adverse drug reactions. It's going to improve your drug efficacy, and perhaps in the long run, maybe even shorter hospital stays. And what we are really trying to now do is to find the economic value to implementing pharmacogenetics for an already low middle income situation. And I think that should really work with policymakers, because we really want to show the value of doing a pharmacogenetic test to be able to provide accurate, but also be able to save money in the process. We've seen such an example from a beautiful study by the PREPARE study, which is a European study, which showed the cost effectiveness in fields of psychiatry and cardiology. It also, from an economic point of view, improves workforce productivity, because you have now fewer drug reaction related absences. And in fact, there's long-term benefit to include healthcare savings and better quality of life. In terms of what is really a challenge for implementation is, of course, we still have education gaps, where there's quite a number of healthcare workers who do not have the exact training or limited training in pharmacogenetics. We still have issues on pricing. I think we all know how the pricing market works, and particularly if we look at the gene therapy area, we still have a lot of work to do to bring those prices down. There's also the requirement of data. Of course, we need much more population-specific data to really understand the frequencies of these variants in different populations in the continent. Then there is the infrastructure barriers, regulatory gaps, partnership hurdles, and social economic barriers. All these that are in one way or the other sort of slowing down the implementation process. But of course, if we really want to implement pharmacogenetics in the continent, we should learn from the PREPARE model. I think we should also try and harmonize the global guidelines and for African settings. We need to sort of develop our infrastructure using established labs which exist, data systems and regional centers of excellence which exist in the continent. We need to sort of piggy bank on those. We need to invest more into capacity building, engage government for policy, and of course engage the public as well. And I think there's more and more success stories that are now coming out of Africa, whether we look at South Africa, which really piloted pharmacogenetics for HIV and cancer, or whether it is Mozambique for nevirapine safety, or whether it is, in fact, using the H3 Africa model for capacity building and biorepositories that it created over the last 10 years. And I think we need to build on those success stories to really ensure that pharmacogenetics is something that's clinically translational. One other thing that I wanted to mention was also what are the factors that contribute to underreporting of these adverse drug reactions, particularly by clinicians in sub-Saharan Africa. As I mentioned, one is lack of competency or maybe lethargy towards pharmacovigilance. There's lack of incentives. Maybe they also believe that only the fatal ARDs should be reported, maybe fear of submitting these reports, believing that they will have no consequence, etc., etc. So there's a lot of this mindset that needs to sort of be tapped into in order for us to be able to report more accurately and more properly in terms of what's happening. And so if we really want to sort of get towards implementing actionable steps towards implementing pharmacogenetics, I think what we really need to do is to promote African-led initiatives where Africans are in fact in the leadership position as far as research and decision making is concerned. We need to then tailor the precision medicine strategy, so really adapt to what the African continent needs, particularly looking at the social, economic, and cultural context. We need to find local and international funding sources to secure long-term funding. We also need to leverage, training opportunities, including scientists, healthcare workers, policymakers, from our partners in the West and East, North and South, and finally build on initiatives like H3 Africa. So to sort of get towards the end of my talk, I just wanted to give you a somewhat summary of the economics of personalized medicine. I think if we zoom back into 2003, when the Human Genome Project was over, every dollar that was invested at that time, today, I think when we look at the economic output, it's now at $141. So everyone who invested $1 into that project at that time today is benefiting at 140-fold higher compared to what they invested. I think it's without saying that by really trying to implement personalized medicine, there is a direct consequence to reduction in the money that we are wasting. So there is reduction in the treatment cost. I think psychiatry is one field that has shown that it's really possible to reduce cost when you start to implement pharmacogenetic intervention. When you talk about precision medicine for drug development, I think there is a 17% reduction if you implement precision medicine towards drug development cost, and that's almost like $26 million annually. Then there's also, by implementing precision medicine, there's a cost that we're saving towards oncology, almost $100 billion per year, by avoiding ineffective treatment, and so on and so forth. But also the other way around is true, is that what Africa is really losing without precision medicine is by not taking any action, is that we're losing about $5 to $15 billion a year simply by not taking into account the cost of the hospital budgets as far as adverse drug reactions are concerned, the cost of the delayed diagnosis for rare genetic conditions that easily could have you could have avoided death and misuse of the care, which can cost millions. The cost of not implementing precision medicine just for sickle cell disease in one country alone, Nigeria, is about $1 billion a year. Then we can get into cancer mismanagement and outbreak responses and all these things where if there was a precision medicine intervention, we would as a continent be saving about $5 to $15 billion a year. And so I think there is a lot of food for thought in terms of where we are in Africa as far as pharmacogenetics is concerned. Yes, we understand there is a lot of diversity, but that's also an opportunity because in a globalized world that we're living in today, it is in fact very much important for the rest of the world to understand the African genotype because it helps them as well. There's also lots of opportunities to piggyback on researches that our brilliant scientists in Africa are already doing, and there's a lot more to be done in terms of trying to make our policymakers understand the importance of precision medicine as far as health economics is concerned. So in summary, I just want to say that pharmacogenetic studies in African populations are less abundant than other populations. We know that. Several studies, however, are available on pharmacogenetics of warfarin and the dosage requirements. There is a lack of pharmacogenetic studies in some diseases, but in Tanzania, we're trying to deal with that as far as sickle cell disease is concerned. A lot of our studies are focused on infectious diseases, and particularly on the drugs like efavirenz for HIV and rifampicin for TB. But of course, disease-specific pharmacogenetic screening panels, in fact, are becoming a reality and feasible in the future. And I think more precise medication for African patients will definitely save the healthcare system, as well as the costs for inadequate treatment or the need to adverse side effects. And with that, I just want to, my favorite quote, I think, is Africa's people really must be able to write their own genomics agenda. And it starts with really getting more diverse funds. With that, I want to thank you for your attention.